Hello my dear friends. Pre-placing a Wong pocket hydration incision along with a clear corneal incision at the beginning of the surgery will give you an edge in achieving a good wound sealing and good wound stability of the clear corneal incision, especially in certain challenging cases of hard cataract phacoemulsification, where you can expect the patient to have some sort of a corneal burn or a corneal wound gape. After making the side port incision, I put a little amount of xylocaine, 1% xylocaine, and then I'm creating the Wong pocket first. A small stab incision without entering the cornea, and posterior to this incision, I create the main clear corneal incision. Now this Wong pocket is going to give me an additional safety margin, ensuring good closure of the wound in case I do find it difficult to seal this clear corneal incision towards the end of the procedure. Of course, you can expect, especially if you're going to deal with a pretty hard cataract, as in this case there is a grade 3 to 4 nuclear sclerotic cataract. After performing a rhexis of about 5.5 millimeters, I do a careful cortical cleavage hydrodissection. You can see the rise of the nucleus and the free rocking of the nucleus, which would tell me that this nucleus is definitely going to rotate later on. Phacoemulsification is then being performed through the clear corneal incision using the direct chop phaco technique. Now, because of the dry spot that occurred on the cornea, I am not able to see the depth to which I buried the phaco probe. This was quickly rectified with the application of viscoelastic on the cornea, but the hold was not good enough to drive the phaco tip to the adequate depth, and hence I didn't get a very satisfactory chop at the first go. Well, subsequently, I buried the phaco tip a little deeper, and this time I was able to get the chop to go through and through and split the posterior plate as well. As it is my practice, especially in harder cataracts, I aim to create multiple small fragments because this will give me greater control in the fragment removal stage. The smaller pieces means that the handling of these pieces is easier. The runoff smaller fragments that ensue from the emulsification of this piece also is smaller, which means that the fragments hitting against the endothelium is also lesser, which of course means that you can end up with a much clearer cornea in the first postoperative day. Therefore, always aim to create multiple small size fragments, especially when you're dealing with hard cataracts. I find that while trying to separate this fragment, the endonucleus separates from the outer epinucleus shell. At this point, I decide to put in Viscoat. While injecting Viscoat, it's important to cut the irrigation off and get a good semi-fill of the anterior chamber. Do not fill the anterior chamber completely with Viscoat. Inject Viscoat so that it coats the endothelium, and there is sufficient amount of fluid underneath it to allow the phacoemulsification to occur. The procedure is now being carried out. The fragment removal stage has happened. The fragment removal of this rather dense cataract is being done in the multiburst mode setting with a power setting of just 40% and a vacuum of 350 millimeters of mercury. I'm slowly able to downsize these fragments, and I'm able to successfully remove it. Make sure that you stay in the center of the eye, allow the pieces to come one by one to the phaco tip, after which you emulsify. Well, one good dictum is every 2 nucleus fragments that you remove is a time for re-insufflating the anterior chamber with the dispersive viscoelastic so that the endothelial protection can be ensured. The last 2 fragments are now being removed. I have exchanged the sharp tip chopper with a Sinskey hook at this stage in order to increase the maneuverability of the second instrument within the eye. I do not reduce the vacuum towards the final pieces. This is because of the good chamber stability that I get with my phaco machine. And now the last piece is being emulsified. You see how some of the epinucleus is getting stuck to the endothelium. It's a good sign. It means that the endothelium is being covered with the dispersive viscoelastic, which being very sticky tends to attract and make pieces stick onto it. Now, once the nucleus emulsification is over, for cortical aspiration, I prefer to fill the chamber with methyl cellulose because it is more malleable and easier to handle, and in this case anyway, because of the very good cortical cleavage hydrodissection, there is hardly any cortex left behind. The intraocular lens is then being gently implanted within the capsular bag. Well, the posterior capsule can be little thin and floppy, and that is why I take my time and inject the lens very slowly inside the bag. And once I have achieved this effect, the remaining part of the procedure is that the viscoelastic should be washed out. When using methyl cellulose as the viscoelastic agent, I generally do not spend so much of time in the anterior chamber washing out the visco. But if you use a dispersive viscoelastic, especially like Viscoat or its equivalent, then you should give sufficient time, almost a minute or so, for good aspiration of all the viscoelastic material. Otherwise, it will produce a spike in the intraocular pressure in the postoperative period. Patient may complain of pain and also blurring of vision due to steamy cornea. Now, final step is to hydrate the incision. So, I do the conventional hydration by injecting a little amount of fluid into the stroma, and then I supplement this with an injection into the Wong's pocket. Now, creating a Wong's pocket after the surgery has been completed in a hypertonus eye can prove to be difficult, and that is why in certain high risk patients, especially when I am anticipating that there could be difficulty in reforming the chamber, I like to pre-place the Wong pocket incision in hard cataracts, and also when I see that the cornea is looking a little thin at the site of incision. I hope this video has been useful and will help you in the handling of hard cataracts and getting good watertight wound closure. I thank you all for your attention.